detailed preoperative evaluation always contribute towards reduction in morbidity and mortality. Second, morbidity and patients on multiple drugs, and we anesthetize patients for complex surgeries with limited resources. So it's very important to optimize these patients' physiological status preoperatively to avoid delay and postponement of the operation on the day of the surgery. Second slide. Yeah. So it's quite important to identify patients vulnerable to complications, and then you can optimize them preoperatively, and you have to get them, return them to desirable functional activity as early as possible. Sometimes, we anesthetize patients for major surgeries, and then they recover, they go home, but they take many months to get back to their normal daily living activities. Concentrate on the history. Next slide. Next. Okay. So when we take the history, like age of the patient, and you have to assess the current the surgical needs, and then you have to assess all the diseases related to all the organ systems. Next slide, please. Yeah, so the diseases related to various organ systems like diabetes, ischemic heart disease, hypertension, and then symptoms or features of anemia. So you do a systematic evaluation, and also you take the prior anesthetic history, the previous slide, and to see whether there had been any airway related issues in the past. And then you have to see, get the history about the drugs. So if they have comorbidities, they may be on multiple medications. So you have to assess about the current medication, the compliance, allergies, and then you take the family history, and then habits like smoking and alcohol. Now these current medications, next slide, the other one. Most of the drugs that they are on, you continue with a sip of water, right? And then the other one. But the certain drugs you may have to stop. The other slide. The certain drugs you may have to stop, especially anticoagulants and antiplatelet agents. If the patients are having prosthetic valves, you will have to stop warfarin 3 days before the operation and put them on bridging therapy with heparin. And the patients on dual antiplatelet therapy, then if you are planning to give a neuraxial block, you stop it 5 to 7 days before the operation. This problem comes when they are on dual antiplatelet therapy, but if they are on single antiplatelet therapy, it's not a problem. If the patients are only on aspirin, that there is no contraindication for a neuraxial block. But if these patients, in cases like fracture neck of femur, elderly patients, if they are on dual antiplatelet therapy, still we have to weigh the pros and cons, and you may go ahead with spinal even if they are on dual antiplatelet therapy. Next slide. Right. The next important aspect of your preoperative assessment is evaluation of functional capacity. By evaluating the functional capacity, we get an idea about the patient's physiological reserve capacity, that so that we will get to know whether he can withstand surgery with minimum complications. I can't see it. Yeah, the functional capacity is defined as the activity that the patient can perform. One individual can maximum or near maximum activities that the patient is capable to perform. So that is the functional capacity, and this is expressed in terms of metabolic equivalence. So the metabolic equivalence is oxygen consumption 3.5 milliliters per kilogram per minute, And that's the resting oxygen consumption of a 40-year-old 70-kilogram man. So anyway, by assessing the MET value, now say if you know the MET value and if the MET value is less than 4, this patient has poor functional capacity. How do we assess the functional capacity? Next slide. Yeah, there are subjective methods and objective methods. The most of the time, we use subjective method to assess this functional capacity. Next slide. Yeah, the subjective methods, we always ask the patient about the stair climbing or the activities of daily living, and then we assess the MET value according to his daily activities. So when we take stair climbing now, we ask whether he can climb one flight of stairs. So generally we say if the patient can climb one flight of stairs, that is equal to 4. And then if you take the staircases, the number of steps differs in each staircase and even the height. So generally the staircase, the 20 steps and 4 inches height, that's what we have to take. But then this number of steps may vary from 18 to 22. Then according to the activities of daily living also, we can assess the MET value. Next slide, please. Subjective methods. But anyway, if someone's, by assessing the stair climbing, if someone's MET value is less than 4, we generally can take it as MET value of less than 4, and that person is prone to have more cardiovascular complications intraoperatively or post-operatively. Next slide. From the objective methods, you can get a better prediction of MET value, and there are 6 minutes walk test and incremental shuttle walk test. 6 minutes walk test means that you get the patient to walk 6 minutes, and then you assess over a certain distance, and then you assess the clinical parameters like heart rate, oxygen saturation, fatigue, shortness of breath. And the incremental shuttle walk, you get the patient walk a distance between 2 cones, and then you keep increasing the speed. So these are 2 objective methods. The best method or the gold standard of assessing functional capacity is cardiopulmonary exercise testing. Next slide. Now this cardiopulmonary exercise testing, you assess both cardiac and respiratory system as well as musculoskeletal parameters. Even though this is the gold standard, and this is used only for major surgeries, and it's not available everywhere, and it's time consuming, and you need trained personnel. So therefore we have subjective methods and objective methods. Out of these, we generally use subjective methods, stair climbing. We know that if the MET value is less than 4, that person has poor functional capacity and more prone to complications, and you need to optimize that patient preoperatively. If the functional have good functional capacity, moderate to good functional capacity, we can proceed with surgery, that is by the CPET. You can get the accurate value, and then if it is if you get a good moderate to good functional capacity, you can proceed with surgery without further testing. Okay, so most of the time we stick to subjective methods, that is the stair climbing. Next slide. Next slide. Right. So once we take the history, our next important the part would be the physical examination. So you have to examine the patient systematic way, paying more attention to the cardiovascular and the respiratory system, and you need to assess the airway. Next slide. Next slide. Need to next slide. Okay. So the careful examination of the airway and the spine, systematic and complete review of organ systems, and anthropometric measurements, and you need to record hemodynamic parameters. Next slide. Yeah. So once we do the examination, then we have to do only the relevant investigations. It's not necessary to do a lot of investigations, and you do the investigations only if they are indicated. Like a fit, healthy person, you don't need to do any investigation. Yeah. So now to decide what investigations to do, you need to consider about the age of the patient, medical conditions of the patient, and grade of the surgery. Next slide. Right. So do only the relevant indications, and please do not postpone surgery just because that the investigation report is not available in the theatre. And the other thing, you don't need to repeat certain tests. Say like within past 2-3 months, if the patient has said renal profile or a full blood count, and if there has not been any clinical deterioration from that day onwards, you don't need to repeat this investigation. Now, if the ECG within the past 1 year, if there is an ECG and if there has not been any clinical deterioration, you don't need to repeat the ECG. Okay, the next slide. Yeah, there is a comprehensive guideline about the investigation, which has been published by the College of Anesthetists in April 2022. You can go through this guideline about the investigations because I have no time to go through all these investigations at this moment. Okay, next slide. Next slide. Next slide. Okay. Now, most of our patients are unscreened. Lot of the patients are anemic. So, if you come across, so generally you need to have a hemoglobin concentration of 8 to 10 to undergo surgery. And in certain cases, lower levels are accepted, like in patients with chronic kidney disease. And this cardiac patients, you need to have a hemoglobin level of 10 grams. So if someone is anemic, then in that case, you need to improve his hemoglobin percentage. So if you have time, you can put them on oral iron therapy, or depending on the time frame, you can give them IV iron, or you may need to give blood transfusions to improve the hemoglobin level. Okay. Next slide. Right. So once we do once we take the history, examine the patient, and do the investigations, then we have to assess the risk involved with anesthesia and surgery. Now, this next slide. You can assess the ASA status. So you can do the risk assessment by ASA status. The next slide. Yeah. So all of you are aware about this ASA classification. Only thing, this does not take into account the patient's physiological reserve, type of surgery, and things. So each and every patient, we do this ASA assessment. The previous slide. Other than that, there are other disease-specific scoring systems like stop-band score in obstructive sleep apnea. And in obesity patients, there is the score. And then the patients with ischemic heart disease who undergo non-cardiac surgery, then we can do this risk assessment by Lee's revised cardiac risk index. Next slide. Next one. Yeah. So the Lee's revised cardiac risk index, it has 6 factors. Now, depending on the number of factors one patient has, you give a score. So generally, if someone has more than 2 factors, that patient is at high anesthetic risk. Okay, so if they have high the anesthetic risk by assessing the Lee's cardiac risk index, that indicates that the patient is going to have adverse cardiac events intraoperatively or post-operatively. Next slide. Okay. So why do we assess the risk? So there are risk assessment scores, prediction tools. Now, from all that, we can identify the patients at high anesthetic risk. And also by assessing the functional capacity, then again, we can identify the patients who are at high anesthetic risk. So now the risk assessment in conjunction with the functional capacity, we can decide whether to proceed with surgery or not, or whether to use any other alternative methods regarding optimization. So by assessing the functional capacity and by assessing the anesthetic risk, we can triage appropriate levels of care for this particular patient. Next slide. So if someone has high anesthetic risk or has poor functional capacity, then we need to optimize this patient to attenuate the risk. So there can be we need multidisciplinary input for optimum clinical optimization. And you have to improve pre-existing comorbidities pharmacologically, and we can modify risk factors, lifestyle modification. And the other important thing is enhance functional capacity to increase the physiological reserve. So I told you at the outset, so now post-operatively, we have to get back to the patient for their normal living activities as soon as possible without taking many months, especially in major surgery. Okay, next slide. So now enhancing functional capacity is known as prehabilitation. Prehabilitation is enhancing functional capacity of an individual before surgery to withstand the forthcoming stressor, especially major surgery. Now, this prehabilitation is important, especially in patients who undergo major surgery, the major bowel surgery, cancer surgery, malnourished patients, elderly, frail patients. They are the patients who will benefit from this prehabilitation. They are the patients who will be subject for prehabilitation. Next slide, please. Okay. So prehabilitation is a multimodal approach, and it involves medical optimization, physical exercise, nutritional support, and psychological support. Next slide. Next slide. Next slide, clinic. And then if you know the say if it is major bowel surgery, and if you know the scheduled date, so there is time. Okay, next slide. So there may be a like time period like between 3 to 4 weeks, like. So during this time, you can, no, previous slide, please. Okay, there is another. So during this period, say from the time that you assess the patient in the pre-op assessment clinic and the time the patient undergoes surgery, if there's an adequate time, during this time you can subject the patient for prehabilitation. It's actually a teachable moment. And then the patient also wants to undergo surgery and get back to their normal life. So the patient feels more capable of exercise than any other time. So it can overcome physical unfitness, malnutrition, anxiety. It facilitates recovery process. Next slide. So the medical optimization, you have to do pharmacological optimization to gain optimum control of chronic condition and management of anemia, control of blood glucose, of smoking and alcohol intake, and rehabilitation, they are drug addicts, and weight optimization. Next slide. Yeah. So the physical exercise program, this is very important to improve their muscle strength. And there are various exercises like aerobics, the resistance exercises, balance training, all that will enhance physical fitness. But first you have to assess the patient's baseline functional capacity, and then you have to give a structured and personalized exercise program which is appropriate for that individual. Okay, next one. Next. So assistance exercises are more helpful who have lost muscle mass, and balance and flexibility exercises useful in older patients. And the least fit and most sedentary patients show more improvement from this physical exercise program. Next slide. Yeah, so this exercise training, it could be home-based so that you can teach the exercises, they can go home and do the exercises. And if you're not sure that they will do the exercises at home, you can get them to hospital and supervised by a professional, and you can get them to do this exercise training under supervision. And you have to this program should be very clear and well defined. If you feel that the patient may not adhere to this exercise program, you can ask them to come with a relative or a friend so who will understand about the exercise program, and then they can go home and do the exercises a better way. Next slide. Yeah, so this slide shows different exercises. The other one. Okay. Now these patients, it's very important to improve their nutritional state. Now to start with, they might be malnourished, they have poor nutritional state, and they are subjected to surgical insult, the nature of the surgery. All that will lead to a catabolic state. So now you have to counteract this catabolic state to support anabolism in synergy with exercise. Next slide. Yeah, to stimulate muscle protein synthesis, you can give whey protein, and it's immediately after a bout of resistance exercises. If you give it, you can support muscle protein synthesis. And also things like immunonutrition will be useful for promote wound healing and reduce infection rates. So it's quite important to assess the nutritional state and optimize their nutrition before surgery. Okay, next slide. Okay, the other one is the psychological support. These patients are very anxious and stressed out. So you can teach them relaxation techniques like deep breathing, the progressive muscle relaxation, meditation, and cognitive behavioral therapy. So development of positive attitudes and problem solving and coping strategies. So this rehabilitation is a multimodal approach. You have to do the medical optimization. Then you can have to subject them for exercise programs, nutritional support, and psychological support are the components in rehabilitation. Next slide. Okay, so how long should you subject them for rehabilitation? So even if the 3 to 4 weeks would be sufficient to rehabilitate and improve their physiological reserves. Next slide. Okay, so now the most of the time it's you, the medical officers, who are at these pre-anesthetic clinics, and then the patients who undergo these major bowel surgeries, cancer surgeries, like frail, elderly, malnourished patients, they will be referred to the pre-anesthetic clinic. And this rehabilitation program is useful in major surgeries, like the patients whom I mentioned just now. So when they are referred to the pre-anesthetic clinic, it's the medical officer who sees this patient first in the pre-anesthetic clinic. So once if the decision is to proceed with surgery, so you need to do prehabilitation. You need to subject them for prehabilitation. So you can get about this the perioperative physician to improve their the medical conditions, and you can get the support from this sports medicine unit regarding exercises. And if there's a medical nutrition unit, you can get them to improve the nutritional state of the patient. And if there is the psychotherapist or the psychiatry unit, if there's someone who can do counseling, you can get that patient's help to relieve the anxiety. And then you can have to advise about cessation of smoking and the other things. And you have to see whether the patient is undergoing this prehabilitation program. So once you improve the them medically the risk status, and once we improve the functional capacity, and after doing all the other relevant investigations, then the patient can undergo surgery. Okay. So this prehabilitation, it is done for major surgeries like major bowel surgery, cancer surgery, frail patients, malnourished patients. They are the patients who are subjected for this prehabilitation program. It's a double concept. So by subjecting them for prehabilitation, it leads to swifter functional recovery. Okay, the other slide. So that's the end of my presentation. Thought of putting 2 questions, and the first 2 case scenarios. One is a 60-year-old female patient scheduled for thyroidectomy, referred to pre-anesthetic clinic, and this patient has a background history of hypertension. What are the important aspects of her history? Can someone speak up and tell?
Preoperative blood pressure control.
Okay, so this patient has hypertension, and you have to see the control of his disease and the compliance of his medication for hypertension. Okay, but it's a thyroid surgery.
It will need
but don't take, because we don't have much time, don't take long time.
Whether the patient is clinically euthyroid?
Yeah, so thyroid
hypothyroid.
Sorry, yeah, thyroid status of the patient. Anything else?
ARVs.
Yeah, so if has the patient got any ARV issues, obstructive features? Right? What are the important aspects of examination? Sorry? Then
it's difficult ARV.
Yeah, ARV examination and the systemic examination. And
laryngoscopy, indirect laryngoscopy to assess vocal cords.
Okay. And I forgot something in the history. You have to assess the functional capacity of the patient. Okay. So what investigations would you request?
Thyroxine levels.
No, that has to be, should have been done that is not a preoperative investigation. Now it should have been done in the past. Now for this operation, the patient is undergoing thyroidectomy. You have to know the thyroid state. Chest X-ray. Okay, so if there's some retrosternal extension or something, you can do a chest X. Otherwise, it's not necessary.
Neck X-ray, AP lateral.
Yeah, that is depending on the goiter. And if you think that there's a compression or deviation, you can do it.
ECG we have to take.
Okay, yeah, because this patient has a history of hypertension. And if the ECG has not been done within the past 1 year, you have to do a ECG. Okay.
Renal functions.
Yes, the patient is hypertensive. You have to know the creatinine value.
Echocardiogram.
You don't need to do an echocardiogram just because the patient has hypertension. Unless the patient sorry? You need to, sorry?
Hypertensive heart disease.
Now, if you suspect or if there's some clinical evidence to suggest that the patient has the heart disease, then you can do. Otherwise, just because the patient has hypertension, it's not necessary, and the echo should not be done. And the other thing, you need to do a full blood count. Baseline hemoglobin level. Okay, we'll take this the next scenario. That's a 60-year-old female patient. Schedule scenario 2. Next one. Next slide, please. Yeah. You have a 70-year-old male awaiting surgery for sigmoid cancer. Then again, this patient is referred to the pre-anesthetic clinic. And this patient has a background history of ischemic heart disease and diabetes. And he also complains of weight loss over the last 6 months. So what are the important aspects in the history?
Ischemic heart disease and diabetic with malnutrition.
Sorry?
Ischemic heart disease and diabetic and malnutrition. Weight loss for all.
Yeah, so what are the important aspects of his history?
Nutritional prehabilitation.
Can you speak loud?
Nutritional prehabilitation has to.
Yeah, he has a weight loss. So that we have already given that. What are the other the things that you need to find out from the history?
When was the last ischemic heart disease attack?
Sorry?
Functional capacity.
Okay, so functional capacity. And you have to assess the...
Diabetic drugs, diabetic control.
Yes.
Macro and microvascular complications.
Right, okay. And since this patient has sigmoid cancer, whether the patient has undergone neoadjuvant chemotherapy and the related to the cancer, other constitutional...
Nourishment status.
Yeah, okay, someone said that.
Metastasis
Sorry.
of the cancer. Whether he has metastasis.
Right. So, and you have to assess the functional capacity. And because this patient has ischemic heart disease, to assess the risk, you can use the revised cardiac risk index. Okay. So the important aspects of examination.
Lung function test.
No, you don't need to do lung function test unless there is an indication. This is sigmoid. I have not come to investigation. Now say you have to do a systematic examination of the cardiovascular system, respiratory system, and assess the RV, and you need to assess BMI. Okay, so what are the investigations? Now this is a 70-year-old patient with ischemic heart disease and diabetes.
2D echo.
2D echo only if there is an indication. And if the echo has been done, even then, if the echo has been done within the last 1 year, you don't need to. Say suppose in this patient has undergone chemotherapy and then there is some cardiotoxic, it can cause cardiac toxicity. So if you feel that he has cardiac toxicity, then you can do an echo. Okay, what are the other the investigations?
Basic investigation, ECG, full background. Basic investigation, ECG, and the renal function test, and assess diabetes, HbA1c to see the
Yes,
last
HbA1c has not been done within the past 3 months.
Yeah.
Serum protein, the liver function test, serum electrolyte. So these are the investigations that you need to do because this patient is 70-year-old and he is a patient with ischemic heart disease and diabetes. Okay, so now this patient, he has a weight loss. He is undergoing major surgery. And the elderly patient, he may have features of frailty. He is a good subject or he should be subjected for prehabilitation before surgery. Okay, thank you. The next slide, please. These are my references. Next slide.